This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending here, and today we are diving into a topic that remains one of the most debated areas in adult hydrocephalus.
And I'm Dr. Alara. Today we're looking at a fascinating new study from the 2026 volume of Clinical Neurology and Neurosurgery. The paper is titled Predicting Dementia Severity Changes After Shunt Surgery for Idiopathic Normal Pressure Hydrocephalus, Role of the TAP Test and Cognitive Assessments.
This is a crucial topic, Alara. We see iNPH patients every week in clinic. We know the triad, gait disturbance, urinary incontinence, and cognitive decline, but predicting which of these patients will actually see a meaningful improvement in their dementia after a shunt is notoriously difficult. Often we rely heavily on the gait response to a TAP test, but the cognitive piece is frequently less clear.
Exactly, Dr. Aris. The researchers in this study wanted to determine the most appropriate assessment scale, and perhaps more importantly, the optimal timing of the TAP test to predict those cognitive improvements post-surgery. They compared the Mini Mental State Examination, or MMSE, the Montreal Cognitive Assessment, or MoCA, and the iNPH GS Scale Cognitive, which we call the iNPH GSC.
It's a pragmatic study design because those are the tools we actually have at our disposal. In our practice, we often see a bounce in gait within hours of a large volume lumbar puncture, but cognitive changes aren't always that fast. What did the study find regarding the timing?
That was one of the most significant takeaways. The study looked at cognitive performance at baseline, 1 day after the TAP test, and 1 week after the TAP test. They found that assessments conducted 1 week after the TAP test were significantly better at predicting long-term dementia improvement after shunt surgery than those conducted just 24 hours later.
That's a vital point for the residents and students listening. If you only assess the patient the day after the TAP test and don't see a change in their MMSE or MoCA, you might be prematurely labeling them as a non-responder. The delayed improvement at 1 week seems to be more representative of the physiological change we hope to achieve with a permanent shunt.
Right, and when it came to the scales themselves, the study found that the MoCA and the iNPH GSC were far more sensitive than the MMSE. While the MMSE is a classic, it often has a ceiling effect or just doesn't capture the specific executive dysfunction we see in iNPH. The paper suggests that using MoCA or the iNPH GSC at that 1 week mark provides a much more accurate prognostic window.
It makes sense. iNPH is largely a frontal subcortical process. The MMSE is quite heavy on orientation and memory, but lighter on the executive functions and attention, the very things that the MoCA and iNPH GSC target. Did the paper highlight how these results should change our preoperative workflow?
It did. The authors argue that if we are trying to predict dementia severity changes, we shouldn't just rely on the immediate post-TAP window. For a patient where the primary concern is cognitive decline, we should be bringing them back a week later for a formal reassessment using the MoCA before deciding against surgery. They found that improvement at the 1 week interval was a strong predictor of who would benefit most from the shunt.
This really hits home the idea that iNPH is a chronic, reversible condition, but the reversal takes time to manifest in complex cortical functions. It's also a good reminder for the attendings listening. Don't rush the decision. If the gait improves at 24 hours, great. That's a high positive predictive value. But if the cognitive symptoms are the main complaint, patience in the testing phase is key.
Exactly. The study emphasizes that predicting improvements in dementia severity is a nuanced task. By using the right scales, the MoCA or iNPH GSC, and the right timing, 1 week out, we can better select candidates for shunt surgery and provide more accurate expectations for families.
Excellent summary, Dr. Alara. It's studies like this that help us refine our clinical pathways from guesswork to evidence-based protocol. For our listeners, remember that the TAP test isn't just a 24-hour snapshot. It's a process.
Thank you for joining us on the Neurosurgery Hub podcast. We'll see you in the next episode.
Safe operating, everyone.